Hi, good morning. Good evening, everybody. Not morning now. My name's Dr. Azhar Ali. I'm part of the JRF Executive Committee. I'm here today joined by Dr. Marcus Velasco, and we welcome you to the first inaugural session of the Radiology Specialist Interest Showcase. And this session will go through neuroradiology and musculoskeletal radiology. And we have an exciting line of speakers today, which I'm sure you will be inspired by. I'm just going to go through the aims of why we've created this showcase. And this is kind of the brainchild of the Junior Radiologist Forum and the Executive Committee. So the main aim is to inspire the next generation of radiologists. We often, as a trainee, you may face crossroads. You might be confused about which direction to take within your specialty. Certainly, I know that this was the case for myself and many other trainees that I've conversed with. And sometimes you just don't know what direction to take. You might like a multitude of subspecialties, and you might not be sure about what the future of these specialties hold. You might not have had that much exposure within your training scheme, or you might just be wanting to know more about the special interest group and what they have to offer. So sorry, I think this is jumping. Hold on. I'll just go through. So because of the limited exposure that we have, we created this kind of special interest showcase to really inspire the next generation of radiologists. And the series itself is a platform for radiology trainees to explore this future landscape of the field. We've developed this program to provide you with insights into emerging trends, the challenges, and also the opportunities within radiology and these specialties. And we've broken it down. So we've got a series of focus sessions on various specialist interests so that you can gain a comprehensive understanding of the advancements in the imaging techniques, as well as some bit about the impact of AI within these specialties, but more so the evolving role that radiologists have in patient care. So the format of these sessions, we have 7 virtual sessions, and these cover 14 specialist interests. They will take place between 6 and 7:15 each month. We'll at the end have a Q&A. And we're hoping to have the recordings of these sessions available at the end of the series. So that would be in July time. So the learning outcomes generally would be to help trainees have guidance in making informed career decisions within radiology specialist interests, to facilitate these discussions on the directions of these specialties, and provide you with insights into emerging trends and advancements. Some of the sessions will explore the impact of technology within these fields, but mainly to allow you to critically think, reflect, and evaluate what are radiologists doing in patient care, how this role is evolving, and how does it align with your own interests. So I'd like to thank the team. These things require a lot of work in the background, and I'm really grateful for the Junior Radiologist Forum and the Executive Committee who've helped with the organization of these events. I'm particularly thankful to the Royal College of Radiologists, Dr. Suresh, who was instrumental in helping, but also Anne-Marie. She's been literally so amazing with regards to organization, and emails back and forth. And without her, this project would not have existed. I'm also grateful to Amy Steeds, who helped, start the workings of this project. And finally, I'm very grateful to our esteemed faculty, speaker faculty, who have given up their time and allowed us to benefit from their experience and provide insights into their specialties. So the sessions will run through from January all the way to July. We start off this session with Neuroradiology and Musculoskeletal Radiology. And we have an exciting faculty of speakers today. I won't go too much into this because we'll be introducing them in just a few moments. But the moderators for today will be myself and Dr. Marcus Velasco, and we're both radiology residents, SC4s. And we hope you really enjoy this series. And I give it over to Marcus to introduce our first speaker.
Hi, I'm Marcus. I'm going to introduce the first speaker. That is Dr. Tilak Das. He is a diagnostic neuroradiologist at Cambridge University Hospitals NHS Foundation Trust, having done neuroradiology fellowships in Cambridge and Toronto. He is treasurer of the British Society of Neuroradiologists and has recently held a joint role as the BSNR and Royal College of Radiologists Double Traveling Professor for Neuroradiology. He also contributes to the BSNR Teaching and Education Subcommittee, has delivered several lectures on behalf of the BSNR, and has been a regular speaker at Radiopedia conferences. He has a PhD in developmental neuroscience and is actively involved in research projects on traumatic brain injury using machine learning techniques, quantitative imaging in thyroid eye disease, and parathyroid imaging, all areas that have developed from his clinical interests. He has a keen interest in clinical informatics, having recently obtained a master's degree with distinction from the Cambridge University, and is currently clinical lead for AI imaging in Cambridge. So without further ado, I'll let you go on to Dr. Tilak Das.
Great, thank you very much. Thanks for the kind introduction. Right, so welcome everyone to this first session on neuroradiology. So let me get started here. See if we can get this working first. Okay, how does that look? All right, so far so good, hopefully.
Yeah.
Thank you. So I won't keep an eye on the chat right now, but of course we will have an opportunity for questions and so on later. But I'll let the moderators interrupt me if there's anything in particular that's maybe not working, etc. Great. So the way I sort of thought about the session is that there's probably three groups of people that are here this evening, and one will be, the explorers, the ones who are not sure about what subspecialty they want to do yet, or maybe early in the training, or maybe not, but still not decided, and getting an idea about different specialties. And I hope for you that I'll be able to give you a flavor of what neuroradiology entails and inspire, maybe even. And then there'll be those of you who already know that they want to do neuroradiology. And hopefully for you, I'll be able to provide a little bit of guidance or resources that might be useful further in your careers. And then finally, there'll be those who know for sure that they don't want to do neuroradiology. And maybe you're here for MSK, but hopefully for you, you'll find that a lot of the things that I'm saying in this discussion are actually applicable to any subspecialty. So hopefully you'll get some use out of it. Either way, for everybody, I'd like you to just sit back and relax, because this should be a fairly lighthearted and hopefully fun session. So when we're talking about neuroradiology, it's not just the brain, of course, it's also the spine that we often work on, as well as skull base and head and neck. So there's quite a lot of coverage of the body. and quite varied. And almost all the sort of radiology modalities are represented. So CT and MRI, of course, being the majority of our work, but there's also need or opportunity to work in areas of plain film, ultrasound, and nuclear medicine. And that's becoming a growing area now. And then when you think of all the sort of referring specialties that we have discussions with almost every day and every week, actually, it's a lot more than just neurosurgery and neurology as well. So you can see from this chart that, again, it's a very varied set of surgeons and physicians, psychiatrists, there's pediatrics, there's things that are acute, intensive care, trauma orthopedics, and less acute, perhaps. But very varied. And so what that means is that anyone who has, not everybody will have experience of this before having done radiology. I went through medicine. I certainly didn't have much surgical experience, but then there's such a great variety that any of your clinical experience is extremely valuable within your neuroradiology training subsequently. So something for everybody. And of course, the kind of work we do is similar to any other subspecialty. So a lot of reporting and a lot of time in MDTs. And I'll come back to MDTs again in shortly. But we then often have sort of consultations one-to-one with clinicians or others. And that's where sometimes our expertise and the value that you can add as a very specialist kind of radiologist can be very satisfying. And whether you're interventional, in which case you'll be doing procedures a lot, of course, or diagnostic in neuroradiology, there's still an opportunity to do different types of procedures. So in my own example, I do head and neck, so I do head and neck ultrasound and biopsies, but also spine biopsies and injections. Great. And there won't be very much radiology in this talk, but this is the kind of thing that we see a lot, different brain lesions. And whether you're reporting or whether you're in an MDT or doing a consultation, you often sort of ask your opinion on these things. And it's not just a case of there's a mass in the brain, it needs a biopsy. The management can be very different depending on your opinion of it. And that's where sort of the neuro experience and expertise comes in. So this is, a mass very close to the cortex and subcortical white matter, involving subcortical white matter, and it looks like an oligodendroglioma. So it will have a slightly better prognosis than, for example, an astrocytoma or wild type GBM type of tumor. Well, here you might be asked, well, what should we do next for this patient with this mass? And in fact, this, having looked at all the other sequences, etc., looks more like a MET than anything else. You might worry about an abscess, but actually it looks more like a MET, so it doesn't need surgery overnight, needs a staging CT and other workup. What about this patient who has this enhancing mass? They've got a history of lung cancer, which has been treated in the past. But actually, if you look at the characteristics of this one, it's very cortical enhancement, it's gyriform, and this looks much more like a subacute infarct. So this patient doesn't need any of treatment for malignancy at this stage, and they actually need sort of stroke workup, which is completely different. And here you'll see this and then decide, well, this actually looks more like a lymphoma. So please don't give this patient steroids, because when they get their biopsy, if you have given them steroids, that lesion is going to melt away and you'll have a negative biopsy. On the other hand, this patient here has a ring enhancing mass, but it's slightly broken. Do you see on the lateral aspect here towards the cortex? And this looks more like MS. So this is tumor factor MS. So here you can tell the surgeons, oh, hold on, this is a surgical planning scan. They don't actually need surgery. How about we repeat the scan in a month and see how things go? This looks more like inflammation. Okay. And then here is a typical abscess. So when you see this, you would say, okay, this is not a MET. This needs urgent drainage if possible, and certainly antibiotics. And then finally, this huge mass in the temporal lobe. actually is very dark on T2, and that's very characteristic of an adenocarcinoma. So I know that this is an adenomet, and that's what we need to go hunting for. So it just gives you a flavor of the kind of decisions that you're making, even for a single thing like a lump in the brain. The scope of practice for neuroradiologists is actually very wide. So most of us will be in tertiary NHS hospitals, but there's work in private practice, in teleradiology. Of course, some of us will be involved with universities, so in research and clinical posts, so academia. And then there's plenty of demand for neuroradiology or neuroimaging in industry, whether that's pharmaceuticals, health tech, sort of startups, especially with AI, of course, and others that are using neuroimaging in their processes. And aside from doing your radiology sort of clinical job, just with any other specialty, there are many opportunities to do research, teaching, and management. Those three were the sort of traditional areas that people would say you could go into, you could develop on top of your clinical job. I would add a fourth one now, which is informatics. Of course, I have an interest in that area, but I think that's an area where there's a lot of clinical need, including for brain and spine imaging. And then finally, of course, there are many other areas outside of these institutions where a neuroradiologist can provide a lot of input, from being a medical advisor to companies, consultancy in health tech, government policy and regulatory bodies. And if you think about, for example, the Alzheimer's treatments that are coming out now, they will require frequent scanning. So now this, if that all sort of comes into place, and I'm sure it will in the near future, then suddenly there's a huge demand for scanning that we don't have the capacity for. And who will decide, or who can help decide what's the most appropriate way of doing this? And I think it'll have to be neuroradiologists and not, for example, necessarily physicians who have a little bit of experience of neuroimaging, but not deep experience. And remember also that there's always opportunities for portfolio careers. So you can do a bit of clinical work and a bit of industry work and other things, but the scope is still massive for neuroradiology. So I'll talk to you a little bit about career paths. So this is my path that I'll tell you a little bit about. So I did my undergrad, and then actually did preclinical medicine and then did a PhD, intercalated PhD before doing clinical school. And at that point in time, I worked on zebrafish in developmental neuroscience. So I always had a little bit of a neuro kind of inclination. But really, at that point, I worked in zebrafish retinal development. And these are images that struck me at the time, and I think were the key to me getting interested in imaging as well. And this shows retinal ganglion cells injected with green fluorescent protein that have guided their axons all the way to the tectum in zebrafish. And just the idea that you could visualize that so specifically, excuse me, so specifically, kind of blew my mind at the time. And that's the kind of thing I became interested in. So in clinical school, I maintained an interest in imaging. Then I did a couple of years of medicine with sort of stroke and those kinds of rotations where I could, but also things like cardiology, so completely separate from neuro. And then radiology training. And I was one of those people that wanted to be sure that I wasn't missing out on something else. So I did enjoy quite a lot of different subspecialties. But ultimately, when it came to applying for fellowships or those opportunities came up, that's when I made the decision that actually I will go for neuro. Fellowships, I'll just mention very briefly that I think I would highly recommend anyone to look into fellowships, whether here or abroad. It gives you an extra dimension of experience, and you can pick up a huge amount during your fellowship that you might not have had the opportunity to in your regular training. So highly recommended. But the negative aspect of that is that it is expensive. There's a financial cost to it. You often don't get paid as much as you even did as towards the end of your reg jobs. So there is something to consider there. So finally, after my fellowship, I did my fellowship in Toronto, came back here and got my consultant jobs. And then after becoming consultant, I continued to sort of start doing more and more lectures. So that was experience that I built up over time. And I find that to be an excellent way of learning for me. So I still enjoy doing that. And I'm very involved, as you heard, in society. So I'm now very involved with the British Society of Neuroradiologists, but also on committees and so on of others. And then finally, as part of my outside of clinical neuroradiology work, I've become involved in informatics and AI. So it just keeps the whole job interesting. But that is just one path of many. And if you speak to 10 radiologists, you'll find 10 completely different ways of having come to that same point of becoming consultant. And then after that, doing lots of different things. So I think the point I want to make here is that don't worry about the path that you're taking, whether you've done a PhD or not, whether you've done research or not. Everybody's skills are useful in this field. So I asked many of my colleagues and some of our senior regs, what they kind of felt motivated them to become neuroradiologists. And these are some of the words that came out in a word cloud. Of course, neuro-focused things, but also, fascination with the area, wanting to, focus on patient outcomes that they could see neuroradiology making a difference to, problem solving, and generally passionate about this area. Okay, so let's talk a little bit about potential library of resources. This is obviously an extremely modern library where you've even got scanners within it. I wonder where that might be. Right. So websites, typical ones that you already know about. So radiographics, I think for neuro content is excellent. So these QR codes will take you directly to some of the focused content. So this is for the top 10 lists in neuro. Highly recommended sort of set of lists that they've compiled. Really good. And then the ASNR, American Society of Neuroradiology, has a publication called Neurographics, which has some very good reviews in it. Radiology Assistant and Radiopedia, I'm sure you use them already. And sometimes some of the areas lack a little bit of depth, but they're extremely useful. And Radiopedia, of course, has grown into an amazing resource now. And what about textbooks? So I haven't read a neuro textbook for a little while now, but the one that I really enjoyed when I was training was Requisite's version of Neuroradiology. And looking at the latest sort of Brain by Anne Osborne, that looks very good too, and it's been recommended by some of our fellows. There's one book which is not specific to neuroradiology, although written by a neuroradiologist, that I would highly recommend to everybody at whatever stage of their career. It's a very thin book. It'll take you a very short time to read it, and it's very cheap. But it's called the Radiology Report, and it really focuses on the language and the importance of how you communicate your findings and your report. Really useful. I read it a while after I became a consultant, and it changed my practice in many ways. So highly recommended. The British Society of Neuroradiologists is now quite a thriving society, and since sort of the pandemic, really, they have been very active in teaching and education. So here are some. I'll plug some of our resources. The set of webinars that we have were recorded in 2020 and 2021 by many neuroradiologists around the country, and so there's a set of 66 lectures from 3 or 4 years ago, but still each one is about an hour long with cases and so on to go through. So it's worth having a look. There are a couple of webinars on our website about AI. And at the moment, we do a regular grand round once a month, which is something that you need to register for. The recordings for those will be available as well, but you need to be a member of the BSNR to be able to access that. But for trainees, membership is free. So if you're interested, please do register. And then we run a number of courses. So BSNR has an annual meeting around September, October, and there's usually 1 or 2 days set aside for trainee sort of workshops. So that's worth going to, but it's usually limited capacity. We've had an annual sort of on-call course for the last couple of years, really aimed at ST1 through 3, maybe coming up to on-call including neuro. There's a brand new ST1 to 3 teaching program that's starting in January. And then coming up at the end of this month and also in March is a stroke imaging course aimed at consultants, but as well as general radiologists and regs, and something that's aimed more at general radiologists who have to do who do neuro as part of their job. So a neuro imaging course in March. So you're welcome to have a look at those and see what you think. Other societies have a lot of resources too, and so ASNR has a bunch of lectures. Again, ASNR membership I think is free for trainees. So they have a whole set of neuroradiology lectures, and the Royal College, Royal College Learning Hub has some good neuro content on it too. And if you're interested in research and you're looking for some funding, then have a look at some of the academic side of our of the BSNR, which is the pump priming grant that we provide annually. I think someone's making some nice little annotations on the screen here at the moment. And of course, the Royal College also has seed grants that are open to everybody. Okay, so I mentioned the ECNR courses. This is the European course in neuroradiology run by the European Society of Neuroradiologists. Because I did it in my day, and I found it to be a pretty comprehensive course. But I think the most valuable thing with it for me was actually meeting my peers from around the country, because we all congregated at this course, 4 times in 2 years and got to know each other really well. So that it was an important way for me to get to know other neuroradiologists well during my training. The caveat with this course is that it's expensive. And don't forget your consultants around you. As one of our regs said, that if you approach a neuroradiologist, they usually be very pleased that you're considering it, and we're more than happy to help. So, is there any advice or useful suggestions that I can give you? As a slightly now old hand in this area, well, I can give it to you. You don't have to listen to it, of course. But the first, again, contributed by one of our fellows, is immerse yourself. Get really into it. There's a lot to learn, and it's great fun. But I think you really have to put your heart into it. And the other is stay curious. We're constantly learning, and it's okay to make mistakes. At this stage, you're in an environment where it's safe to make mistakes, and even as a consultant, of course, that we do that too. And we're constantly learning. And indeed, this is a book that I came across a few years ago, which talks about being an expert in any field. And it mentions sort of 3 phases, really. When you're learning, you're doing the time to actually learn the craft. Then you've learned the craft and you're really refining until you finally become an expert and a master, and then you have to pass it on to others. But it doesn't happen just once in your lifetime. It's constantly happening with every new thing that's coming. And ultimately, one of my oncology colleagues said that what they find most helpful is someone who can be really confident with the diagnosis, because there's often a differential, and that comes with time, and expertise and experience. And of course, we need to understand the anatomy, as one of my as Dr. Mitra, who's previous president of the BSNR, said. he heard it from someone else, but work out where it is before what it is. So if you understand the anatomy and you understand how that correlates with the pathology, you can actually find really subtle pathologies much more readily. So here's an example of a patient who had a cheek tumor, and then started having sort of worsening numbness in that side of the face. And you might say, well, it's just he's got a massive tumor there. Of course, he's going to be numb. But if you look at the scans quite carefully, you'll notice that actually, as you track back into the face, there's this enlargement here of the infraorbital nerve. That's here on this side, which you don't see on the other side. And then when you get to this area, the pterygopalatine fossa, a fascinating area, you'll notice that you've lost. This is the normal side. You've got fat intensity there. It's completely lost on that side. And when you look at it on coronal, you can see an impression of a mass-like lesion there. Keep going back. This is foramen rotundum, and that's the maxillary division of the trigeminal nerve. And then finally, there's all this thickening and enhancement of that nerve, and also of the trigeminal itself in the cistern, right up to the pons. And so this is something called perineural spread of tumor. And it's by understanding the anatomy that we often find it. It's not always that readily detectable. So that's what sort of we've identified here. But by really understanding what you might expect to see and where you might expect to see it can be a great help. Okay. And then the MDT. Now, when I mention the MDT, I don't just mean the formal MDT, the oncology MDTs where you're, regular meetings that you go to and you hear people rattle through patients every couple of minutes. You might get a chance to see some scans, and make sense of them at the time, or you may not. But what I also mean is the wider community around radiology. So it's really important, I think, to form good relationships or interactions with surgeons, oncologists, physicians, in our case, neurologists, psychiatrists, ENT, MaxFac, skull base. So there's all the specialties that we looked at in the first few minutes of this have an MDT for you. But that's where I learned so much, where you will learn so much as well, and have huge opportunities for growth. So I think that interaction with others outside of your specialty is really, really important. So the future, is this what the future is going to look like? Overloaded with work, lots of chest x-rays to do at the back there? Of course not. The future is much more like this, isn't it? A robotic radiologist maybe, but very happy nonetheless. But really, even in neuro right now, things have changed really fast. So we've now got mechanical thrombectomy, which is in the arena of interventional neuroradiologists, and with a number needed to treat of 2 to 3, and amazing difference that you can make to patients' lives. So here's a patient with a large vessel occlusion. That's been treated, taken out, flow restored, and they end up with a much smaller deficit than you might expect. So that's here now. This is a patient with bilateral subdurals, and they've got what's called brain sag, something called, and you can see this thickening and enhancement of the dura throughout the brain with headaches, debilitating headaches. This is something called spontaneous intracranial hypotension. And some of my colleagues do this kind of work where one of the reasons for it can be what's called a CSF venous fistula, a CSF leak effectively in the spine, which now the diagnostic neuroradiologist or interventional will be looking for and is also able to treat. So this is fibrin injection in that area to try and seal the hole. Okay, so those things are now, and you can do that now. And there are more things coming, such as middle meningeal artery embolization for subdurals, for example. And then, of course, AI. How could I not talk about the future without AI? So we've all predicted what's going to happen. You can see that here. Elon Musk, self-driving cars, Jeffrey Hinton, radiologist obsolete. 10 years on, we're still driving in our cars in traffic, not themselves. And so AI isn't quite what we thought it would be already, but there are a lot of AI products in neuro. So radiology is one of the largest areas in medicine, and neuro is one of the largest, along with chest, in radiology. And you can find lots of great ads for products and so on. And this is one of my favorite tools that we're using at the moment. This is a patient with MS. You can see all these lesions, and the question is, which ones are new? And so you run the AI and you get a color-coded view, and the red ones are new lesions and the others are not. So you get a much, you can save a lot of time. And I think that's where AI is really going to help with things like measurements and volumes and, menial laborious jobs. But word of caution, there's already now studies showing that there's problems with it. It's been associated with greater burnout and not entirely clear why in radiologists. Or we've shown that despite having all this quantitative data, it actually doesn't improve clinical or traditional visual assessment. So there's food for thought here, because as a neuroradiologist, you should really be involved in the tools that you're using and how you're going to evaluate them, and are they truly useful for you. And I think there's a lot of work to be done in this area, and a neuroradiologist is going to be much better at evaluating a tool for brain scan than a general radiologist or a neurologist or a neurosurgeon, for example. But that is happening. And then, of course, there's all the new technologies that are coming through that will hopefully find their way into clinical practice. And so these are beautiful images from the Human Connectome project, looking at mapping fiber tracts. And can you imagine if we could really understand these well enough to be able to map them clinically in a reasonable amount of time and make sense of them, to be able to say that there are problems with these specific tracts. It's already used in surgery, but not throughout. And then this was just, it is a mind-blowing view. It's something called HIP CT. I need to look up what it stands for, some sort of phase contrast CT. And just look at the unbelievable resolution at which these scans are imaged, about 25 microns, and they can go down to even smaller than that. And I can't fail to be inspired by this kind of imaging. I mean, of course, this is not a live specimen, but it's just the incredible nature of the technology that's starting to come. And this is one of the things that I heard about a couple of years ago, which really I thought was inspirational. This is from a company called Synchron, a radiologist called Tom Oxley. Excuse me. Sorry about that. This is a brain-computer interface, way ahead of Elon Musk's Neuralink. And he used to be an interventional radiologist, and he has worked out a way of putting in this special stent with electrodes in it into the superior sagittal sinus, so that you can put it right next to the motor cortex, then decode signals from the motor cortex and work out what a patient who's paralyzed wants to do, or allow them to learn to try and simulate certain movements so that they can use an iPad or a tablet or a mobile phone. And that's been revolutionary for some of those patients. Amazing, inspiring story. So that's neurointerventional. So in conclusion, neuroradiology is a rapidly evolving field. I think it'll look different by the time you qualify to what it even does now. There's a huge demand in lots of different areas for neuroradiologists. So it's a great place to be. And there's many options aside from just clinical neuroradiology that you can work on while you're doing that. I can't stress enough the importance of building relationships, especially outside of neuroradiology, with your other clinical colleagues. We know that AI is coming, and the question is, how useful is it actually going to be? And neuroradiologists are going to be needed to evaluate its utility in neuroradiology. It's worth putting the work in, because your specialization and your expertise is of huge value, and it's great because we're still learning all the time. So I love it. So hope you will too, if you decide to go down that way. But I think it's the case for many radiological subspecialties. Just want to say thanks to many of my consultant and resident colleagues who've sort of contributed their thoughts to this presentation. Great, thanks.
Thank you very much, Dr. Das. That was an incredible lecture, and a lot of new things that I'm sure lots of the residents here weren't aware of. In the interest of time, we'll go into the next lecture and then we'll have the question and answer session at the end. I'd like to introduce our next speaker. Dr. David McKean is a consultant musculoskeletal radiologist at Buckinghamshire Healthcare NHS Trust. He's currently the clinical lead and radiology research lead for Buckinghamshire Healthcare NHS Trust. He's the director of the Stoke Mandeville Musculoskeletal and Spinal Radiology Fellowship, and he's the radiology lead for the National Spinal Injury Centre. Dr. McKean is dedicated to teaching and is currently the secretary of the British Society of Skeletal Radiologists. He's a member of the European Society of Musculoskeletal Radiology, the Intervention Subcommittee, and the International Skeletal Society Social Media Subcommittee. Dr. McKean has a particular interest in complex spinal intervention. He established a radiofrequency ablation service for the treatment of spinal metastasis and performed the first case of basivertebral nerve ablation for vertebrogenic back pain and the first case of electrochemotherapy for epidural metastasis in the UK. Gives me great pleasure to announce Dr. McKean as our next speaker.
Thanks so much, Azar, for that very kind introduction. I'll just check that I can share my slides. Great. So thank you everyone for coming to the talks this evening. So I'm David McKean. I'm a MSK radiologist in Buckinghamshire, and I'm going to be trying to give you an overall sort of an overview even of some aspects of MSK radiology, which I hope you'll find interesting. So first of all, I'll start with declarations of interest. And I have to confess, I love MSK radiology, and I'm extremely prejudiced against every other radiology subspecialty, as I'm absolutely convinced that MSK radiology is the specialty you should probably be thinking about. It's just great fun. But I'll try and go into that in a bit more detail and hopefully justify that over the course of the talk. So what is MSK radiology? Well, as you know, it's the subspecialty of radiology focused on imaging, diagnosis and treatment of bones, joints, muscles, tendons, ligaments, cartilage and surrounding tissues. So this is an incredibly broad specialty. You've got everything from trauma to degenerative conditions to sports medicine, which is itself a vast area. You've got all kinds of soft tissue tumors and oncology treatments, infections, particularly infections in the spine, all kinds of congenital and developmental disorders, metabolic bone, more developmental disorders, metabolic bone disease, and obviously post-operative imaging. So I think one of the things I would emphasize about MSK radiology is that this is a huge subject. And in addition to the breadth of the specialty just generally, I think you'll find that there's very different experiences depending on where you work and what area you're focused on. So your experience in DGH will be quite different to when you're working in a teaching hospital or potentially in a regional sarcoma centre. And again, your experience will be a bit different, I think, depending if you're working in the NHS or in private practice or in teleradiology or in an elite sports centre. So there's a huge range to the practice in MSK radiology. And I think that's one of the things that makes it such an exciting field to work in. And if I ever forget about, how huge MSK radiology is, I sort of, try and join one of the sort of subcommittees at the ESSR, of which there are many, and the breadth of work that's going on there is really inspiring, and I think just emphasizes the different sorts of practice that people have within MSK. It's obviously very multimodality. I think you're constantly looking at a wide range of different scans. Obviously, lots of MR, lots of CT, lots and lots of ultrasound, lots of ultrasound guided procedures, plain film, fluoro guided procedures as well, and obviously occasionally some nuclear medicine. And again, I think that adds to the variety of the work and helps keep things extremely interesting. Now, again, thinking about AI, following on from the last talk, I decided to ask ChatGPT why someone might want to do MSK radiology, and this is the list of potential reasons that it came up with, which I think is a really good list, and I think I'll hopefully touch on a number of these over the course of the next few minutes. But if you ask me why you might want to do MSK radiology, I would give you a much shorter answer, which is that MSK radiology is fun. It's genuinely great fun. I enjoy my work. I enjoy coming to work every day, and I genuinely think that one of the best decisions I ever made was deciding to do MSK radiology. And I'll talk to you a little bit about that. So, like all sort of stories, you often need good mentors to get you started. And I was very lucky to train in Oxford, and I spent quite a lot of time at the Nuffield Orthopaedic Centre. And I was lucky to be there when some real giants of the field were working there. So people like Eugene McNally, David Wilson, Simon Osler, James Tay, Catherine McCarthy, and Rami Mansour. And then I spent some time over in St Michael as well at the National Spinal Injury Centre, working with Richard Hughes and Tom Ma. And I have to say, these colleagues really inspired me when I was a trainee to want to go into MSK radiology, and the impact they had in my career was immeasurable. I still remember when I was probably about ST3 or so, trying to decide what subspecialty to go into, and I'd come into radiology convinced that I was going to do neuro. In fact, I have Osborne's book on my shelf over here, Tilak, just from my back in the day when I was trying to consider pursuing a career in neuroradiology. And I remember Catherine McCarthy came down to see me to have a chat about subspecialty interests, and she told me she thought I should do MSK, and I was convinced and never looked back. And it's been a really fascinating journey from that point on. One of the things which I enjoy the most about MSK radiology is the patients. The patient group is really, I think, interesting because these are often patients who are going to get better, and they're very pleased to see you. And there's lots of interventions you can offer them which will make them better, certainly make them feel better. And that's fun, and that's very rewarding. And I think that certainly for me, that's one of the best bits about doing MSK. Doing a list of injections, being able to provide patients with relief of their symptoms is incredibly satisfying. And there's something very, very immediately there's something very gratifying about being able to do MSK procedures quickly and well in as pain-free as possible. And the gratitude of the patients is very, very rewarding. And so that's, I think, one of the things that actually steered me away from neuro and towards MSK was that most MSK patients, a lot of them at least, get better, and we can do things that will help them. And at least my experience of neuro, I found made me feel, there were only so many terribly damaged brains I could look at before I started feeling a bit sad. So MSK suited my temperament better, I think. Now, one potential concern you might have is what's it like working with lots of orthopedic surgeons, and it's actually great fun. So for all the stereotypes about ortho bros and so on, I personally find orthopedic surgeons a fantastic group of colleagues to work with. They're very hardworking, occasionally demanding, but they really, I think, do focus, at least the ones I work with, on the patients and providing the best level of care that they can. You could, I think, make the argument that you can divide orthopedic surgeons into a couple of different broad categories, maybe not ortho bros, but certainly orthopedic surgeons who are very reliant on the radiologists with interpretation of the imaging. And that's great because you can really add a lot of value for those surgeons. The potential downside is that they're going to want your reports very quickly. They're going to be calling you on the phone regularly to ask you to give verbal opinions and so on. The Other group you might think about are the orthopedic surgeons, like the ortho profs, who are actually very, very good at looking at their own scans. And they're actually challenging in different ways because you have to work a lot harder to add value to them. But the upside is that you can learn so much from them, and they can really, hopefully you're going to improve their practice, but they can certainly have a huge impact on you and your understanding of the anatomy and so on. So I wouldn't be put off by any preconceptions about what the orthopedic surgeons are like. They're actually great. So the diagnostic side of MSK is really interesting. If you're somebody who likes anatomy, there's so many fascinating areas to think about, and there's always more to learn. So there's always new areas that become hot topics and for you to learn more about. So I think when I was a trainee, for example, I was really interested in shoulder anatomy. I started writing some papers on the rotator interval and the anatomy there. And just as an example, that went on to inspire me to delve into this in more detail, and we wrote more papers. This is an intimate moment between two consultant colleagues in the ultrasound room, demonstrating some procedures you could perform to improve patients' response to injections for the treatment of frozen shoulder. And then you can develop that further. We started doing elastography to measure the elasticity of different ligaments in the shoulder. And then you learn more and write reviews and so on. And it's just an example of how one tiny little area of anatomy can inspire you to write a few papers and develop your practice. And there's lots of other examples of that which I could give you, but just one from the last few years in my experience. The other thing about MSK radiology, beyond just the interesting diagnostic side of it, is that there's lots and lots of intervention. And as I was saying, I personally find joint injections incredibly satisfying, and they're really fun lists to perform. They're quick. The patients are very grateful, and you get great feedback, I think, usually. But there's much more intervention beyond just joint injections, and I'm going to probably go through some examples of that in the rest of the talk, possibly some things that you may not see in your, depending where you're based, you may not have come across before, just to give you hopefully some inspiration about the scope of MSK radiology beyond just doing joint injections. So obviously, ultrasound guided injections are really fun, and if you're good at putting a needle in a straight line, then there's all kinds of things you can do. So for example, think about the rotator interval again. You can perform these very precise rotator interval injections next to long-headed biceps tendon. And that's a very neat way of actually injecting into the glenohumeral joint, because obviously, as you know, that space is in continuity with the glenohumeral joint. So if you inject there, your injectate will flow up. And that's a very, I find, useful way of doing joint injections in the shoulder, because you can do that with a blue needle, regardless of the patient's body habitus, because the biceps is always very close to the skin surface there. And again, you're able to target your steroids into the area where often things are very stuck down if the patient's got frozen shoulder. But then once you master just doing simple joint injections or these sorts of rotator interval injections, there's a huge variety of different things you can do. You've got high volume stripping, dry needling, barbotage procedures, and there's lots of different things you can inject. So obviously steroids, hyaluronic acid, autologous blood, PRP, prolotherapy, Tromial, Botox injections for patients with spasticity. So there's lots and lots and lots of interesting techniques to find out more about. And then beyond that, you can start thinking about doing ultrasound guided releases. So obviously the classic example is annual pulley releases, and these are some images from Gajan's paper from back in 2009 where he described this, and this is a lovely way of releasing thickened annular pulleys in patients who've got trigger finger and sparing them surgery. But you can also do things like plantaris tenotomy in patients where they've got plantaris friction causing Achilles tendinopathy, or long-headed biceps tendon tenotomy. So in patients who've got an unstable, painful biceps tendon who might not be candidates for an operation, you can actually cut the long-headed biceps tendon, assuming they've got an intact short head, and patients' pain resolves very quickly following that because you just release the tendon and off they go. And this is a little gif of me performing this, an example of this a few weeks ago, and that's the scalpel going down, and you're just gently cutting through the patient's long-headed biceps tendon, and then they did very well after that. And then other things like plantar fascia releases are also possible, or even carpal tunnel releases, assuming your local plastic surgeons are willing to give up that practice. And this is an MR showing just the before and after of an ultrasound-guided carpal tunnel release. And then beyond those sorts of interventions, there's lots of spinal intervention, and I have to confess that's probably the area of MSK radiology that I love the most. And again, I'll just give you a few examples of the sorts of things that you can potentially do just for interest. So, I'm a DGH radiologist, but developed an interest in doing complex spinal intervention, and at this National Spinal Injury Centre here, we've got lots of opportunities to do that. You can do things like transosseous bone biopsies, obviously vertebroplasty, but even beyond vertebroplasty, there's newer techniques out there. So this is a spine jack. So if you've got someone with a compression or a burst fracture and you want to try and correct the deformity, so you want to try and prevent that anterior collapse and the associated kyphosis, then you can put these devices down the pedicles into the vertebral body, and just like a car jack, they will lift the end plates up and restore vertebral body height. And so this was an example from, I think, last week, a patient that we treated, and you can see the degree of height restoration that this patient achieved, and their pain was resolved after the procedure, so they went home essentially pain-free. And I think there's even some surgeons in Birmingham who are starting to do these instead of, say, a posterior fixation in very specific cases. But it can be a very effective way of restoring vertebral height in patients with these anterior ridge compression fractures. Has to be done acutely, obviously, because once the bone starts to consolidate, you're not going to be able to restore the height. But in correctly selected patients, this is a really interesting treatment. So I do a lot of work with spinal metastases. So as you know, bone metastases are very, very common and can be a source of really severe and difficult to treat pain. And the mainstay of treatment is radiotherapy, but as we know, there are lots of tumors that are relatively radio resistant, like renal melanoma, sarcomas, and so on. And even patients who do respond to radiotherapy, their pain often recurs in the weeks following cessation of radiotherapy. But there are other treatments that we can offer, usually in a palliative setting, such as radiofrequency ablation, which is where you put probes down into the tumor, you heat the tissues up, because it's protein denaturing and cell death. You can hopefully kill the tumor, and then you can augment the bone with cement to prevent any collapse and prevent any risk of pathological fracture. And this can be an extremely effective technique, again, in appropriately selected patients. So usually we perform this under fluoro. In this case, our fluoro machine was at Forger, so we had to do CT, but you can see the principles here. In this case, this patient had a met within the vertebral body. We put these drills down the pedicles and then place these ablation probes within the vertebral body. This is the Medtronic osteotomy device. So it's a biparticular system. So you can ablate the entirety of the vertebral body in one go. So if you imagine the size of the ablation zones from each probe, that will essentially ablate the entirety of the vertebral body. Usually, hopefully give you some local disease control, and then you augment that with cement to prevent any collapse. And there's lots of data now to show that this is a very effective treatment at preventing the sorts of vertebral-related events that you might otherwise get. So you're not going to get disease progression at that level. You're not going to get pathological collapse or metastatic spinal cord compression at the treated level, although obviously they can get disease progression elsewhere. So this is just an example of a case from last year. You can see here this patient, I think this was renal from memory, the expansion of the vertebral body there. The middle image was from about a week later, I think, and the last image was from about a month later, and you can see that regression of the tumor that we were able to achieve with radiofrequency ablation. Now, it's typically a palliative treatment, but it can provide really significant pain relief and make a huge difference to patients' quality of life at the end of life. And again, we found this to be really interesting work, working in collaboration with our local oncologists. And I was very pleased to be able to advise NICE on the guidelines that were published in 2023 on the use of radiofrequency ablation for spinal metastases. And that was, I think, hopefully an important piece of work for spinal intervention in the UK, because I think if this hadn't been approved, there was a real risk of us falling even further behind our continental colleagues in terms of the sorts of treatments we were able to offer. This is another example. This is a patient who had cholangiocarcinoma. And you can see here the lytic metastases within their pelvis, within the iliac crest, within their ischium. And again, this patient, this was palliative. This patient knew that, but they wanted to be discharged. They wanted to spend the last few weeks, months of their life at home. So we were able to go down, ablate the tumor in her pelvis, in both cases, get good cement fill around that. And this patient was discharged from the hospice a week later and survived for 6 months at home, mobilizing, relatively pain-free, able to walk upstairs. And again, this made a huge impact to that patient's quality of life. Again, was an interesting demonstration of how effective these techniques can be. So another example of some interesting intervention, this is relatively new, although it's been around in the States now for probably about 7 years, which is ablation of the basovertebral nerve. So in patients who've got chronic vertebrogenic back pain, if you ablate the nerve that innervates the end plates, their pain can get better. And as we know, back pain is very, very, very common. If we're able to provide an effective treatment for patients with intractable back pain who haven't responded to conservative measures, then that's, I think, potentially quite exciting. This is some examples of the Intercept device which they're using in the US. That's not available in the UK yet, but you can achieve the same effect with a straight needle as well. So this was a patient who'd had intractable lower back pain for many years, and we were able to go in and ablate the vertebral bodies ablate the basovertebral nerves within the center of the vertebral body at L4, L5, and S1. And that's our ablation needle there at each of those levels. And this patient had essentially complete resolution of their back pain following this procedure. So very new technique, certainly not something that is a good option for everyone, but again, for carefully selected candidates, this has a lot of potential for the treatment of vertebrogenic back pain. And finally, another just interesting intervention, just to mention to you something I think quite exciting, and that's electrochemotherapy for epidural metastases. So as you know, if there's epidural disease, you can't treat that with a thermal ablation technique because you would just damage the cord. And we're usually very paranoid about trying to avoid iatrogenic neural injury. So if there's tumor right up in the epidural space, the natural history is terrible. They often have, very, very severe pain, which progressively gets worse. They get progressive neurology, eventual paralysis, and then a very painful death. So epidural disease that doesn't respond to radiotherapy is extremely difficult to treat with a terrible natural history. But there's a really interesting new technique, really pioneered by Frédéric Deschamps over in Paris, which is electrochemotherapy. So this is a technique where you're placing electrodes around the tumor and then passing an electrical current between those. And the electrical field that you create causes a change in the permeability of the cell membranes within that field, which allows for increased uptake of a chemotherapy agent, in this case, bleomycin. So this was an example from his recent paper, just demonstrating that. I think this is renal. I'll check. I'll check in later. But again, you can see this was the pre-procedure MRI. You've got this extensive epidural disease. This is the placement of the electrodes around that. And this was the follow-up scan at 1 month and at 3 months. And you can see the regression of the epidural disease they were able to achieve. And we had a similar case last year. So this was a patient with prostate metastases who, despite all the radiotherapy that we could give him, had progressive disease, and you can see the extent of epidural tumor there. He'd previously had a vertebroplasty, which had given him some relief initially, but the disease then progressed beyond that. And we performed electrochemotherapy for this patient. These are our 6 electrodes around that L1 vertebral body. This is us trying to decide the pattern, the shape of the electrical pulses we were going to use. This is our patient in the CT scanner, and this is done under general anaesthetic with lots of muscle relaxant. The reason being that when you activate the electrodes and it passes a current, in this case across the cord, the patient's going to jump. So the patient jumps a bit, and everyone else in the room jumps a lot. And then you're given the IV bleomycin, which is working its way around, and then you wait, and then you have to wait and see how well the patient responds. And this was the patient's pre-treatment MRI. This was their MRI 1 month following treatment, and this was their MRI 2 months following treatment. And you can see that epidural disease has just melted away. And so this patient, this made a huge difference to this patient's quality of life again. And he passed away, I think, about 6 months following his treatment with us. But his back pain and his neurological symptoms were relieved by this electric chemotherapy treatment. And again, this is very, very new, but I think has a lot of promise. And it's just an interesting example of one of the new spinal interventional techniques, which I think are coming over the horizon. So MSK research, there's a huge variety of things you can do, everything from sports to sarcoma, everything in between. I try and publish a bit. I don't do as much as I probably should, but try and keep writing whenever I can. I think as a specialty, we don't publish as much as we should. This is a paper from Norwich. This is quite a few years ago now, looking at the number of publications per trainee in different training schemes around the UK, and we don't do very well. Now, it's one thing to think about the trainees, another thing to think about the consultants. Why are we not doing more research? And I think partly the answer is opportunity costs. So the joke would be, whenever you're writing a paper or spending 20, 40, 60 hours writing up some review, that's time you could spend doing other things, whether that's private work or insourcing or teleradiology. So you have to be very dedicated, I think, to want to do research, but it's incredibly rewarding. And certainly, I think some of the most interesting things that I've done have come from the research that that I've been interested in. So hopefully you feel like some sort of radiology Chad, doing some radiology research. Whether you're crying inside is another matter. But now, if you're interested in MSK radiology, I would strongly encourage you to do a fellowship. There's lots of fellowships, but 8 fellowships, established fellowships available in the UK, in Leeds, Oswestry, Liverpool, Birmingham, Oxford, Cambridge, Stoke Mandeville with myself, and down at Stanmore. And I think there are some more, but these are the ones that are on the BSSR website. And I think that a fellowship just gives you so much opportunity to learn more, and it's going to make you a much stronger consultant. It's going to make the first few years of consultant life a lot easier, and I think it makes a real difference, I think, to your career trajectory. And we've had, these are our 10 last fellows that have come through here, and they've all gone on to do very well, and it's been a real pleasure to teach them. So again, I would encourage people to think about doing fellowships if they've got an interest in MSK. And beyond that, there's also opportunities to go abroad. So our last fellow, Veda, who subsequently was appointed with us, arranged to go and do an observership over in San Diego at the end of after her fellowship with us. And I think she had a fantastic experience, learned lots, and was sort of spending time with Christine Chung and Don Resnick over in California. And again, there's lots of opportunities to do that if you want to gain experience in other centres. Finally, well, almost finally, there are lots of MSK societies to join, and I would say that they're very, very fun, very friendly, and I would encourage any trainees to get involved. So there's obviously the British Society of Musculoskeletal Radiology in the UK. There's the European Society of Musculoskeletal Radiology, which often has conferences, usually in June, in these beautiful cities around Europe. It's an excellent conference to attend. And then the International Skeletal Society. This is meetings around the world. It's a fantastic society to join. In order to become a member, you have to, I think, have 6 first name publications, and it's the people who are members of the society are real experts in the field. It's a fantastic conference to attend if you get a chance. But beyond the academic work and the interesting conferences, these are very, very fun meetings. These are some photos from the recent BSSR and ISS meetings, and these are the smiling, happy faces of people who are relieved that they chose MSK Radiology as their subspecialty. I don't think any of them have ever regretted it. So please do join the society, come meet us, and find out more about what it's like being an MSK radiologist. And then beyond the societies, there's lots of courses. So if you've got an interest in, say, spinal intervention, there's an excellent spinal intervention course in Bristol. I think the next one's in March. And that's an opportunity to, again, go meet the consultants, learn about different techniques, and get experience, performing these, under supervision in cadavers. And, getting that hands-on experience, again, is extremely useful. So that's a whistle-stop tour around a few areas of MSK radiology, again, slightly coloured by my personal interest in spinal intervention, but which I hope you found interesting, and hopefully has given you some insight into just the breadth of work that falls under MSK radiology. There's lots of interesting diagnostic challenges, lots and lots of interesting interventional techniques, and obviously if you're doing lots of intervention, you're never going to be replaced by AI. And if you've got an interest in MSK or you'd like to find out more, please don't hesitate to get in touch, either with myself or other members of the BSSR Council, and we'd be really interested to talk to you and tell you a bit more about what it's like in MSK radiology. I just want to thank my colleagues for some of their input preparing the slides for the presentation today, and very happy to answer any questions after the presentation. Thanks very much. Thank you.
Thank you very much, Dr. McKean. That was certainly very inspiring and very interesting to see the scope of what MSK has to offer. I'd like to now open the floor for questions and invite Dr. Das and Dr. Velasco back on screen.
I was a bit worried that I'd end up doing MSK after this. I have to retrain.
It's not too late. It's not too late. But come to the conferences at least. So that's the fun bit.
Absolutely. Yeah.
Yeah, so there was a question in the chat that I think found to Dr. Das, but just going on that thread, what types of jobs would you say, job plans would you say typical for a neuroradiologist?
Okay, so obviously interventional is very different from diagnostic, so I can speak for it much more for diagnostic. And in my job plan, I probably end up doing reporting sessions for about 50% of the time, so not more than that, because a lot of time is taken up by things like MDTs and preparing for those. And I also do some head and neck, so do things like ultrasound sessions, for example. Then I have regular CT guided procedure sessions because over here we do some of the spine work, but of course that varies from center to center, where it'll be a mix or of MSK and neuro doing that. I think my colleagues will have fairly similar kind of distribution of work across their weekly job plans, but everybody tends to end up having some sub-specialization, pediatric neuroradiology or sort of very niche areas within ENT and skull base and so on. But yeah, I would say you're probably not reporting as much as you think you are.
Going on a similar but slight tangent, often we hear from, rumors or murmurs amongst the trainees that, and this is for Dr. McKean, that MSK is a saturated field. What are your thoughts on that statement, and advice regarding that perhaps misconception that there might be?
I suppose it depends what you mean by saturated. If you mean, is it competitive to get a job at a big teaching hospital or in central London and so on, then yes, it is, but it's always been competitive to get those positions. If you mean that there's not enough work for people to do, I would disagree. There is work in every direction, and in in many respects, I think that things have sort of moved on, I suppose, in the last 10 years in terms of the different types of work that are available to consultants wherever they are. So in a time of insourcing or teleradiology, there's opportunities for people to do extra work if that's what they're interested in lots of different ways. So I wouldn't be put off. If you enjoy MSK radiology, I wouldn't be put off. I would try to be as good as you can. I would do a fellowship, I think, and if you're good and you're hardworking, the work comes to you. I think if that's the where that question's leading. The competitive places will always be competitive, but they were before. So I don't know if that's changed very much. I don't know.
Thank you. We have a question on the chat. It says from Rachel. She asks, are there any downsides or things you wish you'd known about your respective subspecialties beforehand? Thank you for the great talks.
So shall I do it first?
Sure.
It's hard. I mean, yeah, I gave a very sort of positive, optimistic view of the thing. I mean, I suppose some of the downsides are some of the pressures that we work under. As David said, there aren't enough of us in any subspecialty to do all the work that needs doing. So we have backlogs, you have big MDT lists, which, despite the joy you get from doing the actual interaction, preparing for those is hard work. And so you have to spend more time doing certain things that you wish you had more time to do something else at that point. So it can be difficult. And that's the part of it is, of course, the nature of the system rather than the specific medicine that we're practicing. I would add one thing to what David was saying about in terms of whether things are saturated and so on. Right. And a bit of advice that I tend to try and give trainees is not to choose a specialty based on where they think jobs are at the moment. So, it doesn't matter if right now in this point in the cycle, there aren't any breast radiology jobs or there are loads of breast openings, but nothing else, because you're going to have your job for 30 years afterwards and things are going to change every 5 years. So go for what you really love.
No, I would wholeheartedly agree with that. I'm just trying to think, what I wish I'd known? I mean, when you're picking a fellowship, for example, the one thing I would say is that they all have slightly different flavors. So depending on what you are interested in, you may want to focus on different places. So if, for example, you want to work in a sarcoma center, you obviously want to go somewhere like Stanmore or where you're going to get that experience. So spending a bit of time talking to people about what the emphasis of different fellowships is, I think is important, because you do get exposed to a slightly different mix of things depending on where you go. I think that would be my other top tip.
Dr. McKean, you talked a lot about the incredible spinal intervention that you do. Do you foresee this being like spreading through the UK and more centres getting involved with spinal intervention?
I don't know, because I'm not sure how many people want to do that. there's a mix. So, for example, in some places, the orthopods will be doing things like the vertebroplasty or the spine jack procedures and so on. So it depends a little bit on the local setup. I think that there are a number of places now which do perform this sort of complex spinal intervention, radiofrequency ablation, and I think the outcomes are really good for that. So I haven't included those cases, but for small tumors, you can perform radiofrequency ablation with curative intent, with similar outcomes to stereotactic beam radiotherapy. And we've had patients who've been PET negative for 6 or 7 years now. The thing to say is that that's obviously not, they haven't just had the radiofrequency ablation, they've had every other treatment that anyone could throw at them. But in combination with all those other things, I think it can be effective. Will this spread across the UK? Well, I'm doing my best to try and encourage people. I'm involved in that course down in Bristol where we train people how to perform these procedures, and a lot of it is, I think, getting comfortable with the techniques. None of them are very hard. They're all essentially variations of the same technique, which is essentially putting a needle down a pedicle. If you can put a needle down a pedicle under either fluoro or CT guidance, then all the other techniques are just minor variations of that. But I don't know how much experience trainees get of that in different centres. So in some places, I think I'm sure you'll get lots of experience, in others less. So yeah, we're very keen to try and encourage people to do this. I think that there's a place for these procedures, and I think they can have a huge impact on patient care. But I take the point that it's not. There is some variability as to where this is available currently.
Sure. I think I have somebody's messaged me a question. Dr. Das, do you think that functional neuroimaging will play more of a role in the future?
Maybe. So, if you look at something like spectroscopy, for example, a joke that some people make about spectroscopy is that it'll always have great potential. And it's been around for a long time, but it used in certain cases, it's extremely useful, and overall, probably the promise hasn't delivered. And so it might be similar with other functional techniques, but things like perfusion and so on, I think there's no doubt that they're useful. It's just very difficult to standardize and that kind of thing. And then the other thing that I think will be now more useful is functional MRI, in terms of, now that we understand things like default mode networks. So, you don't need a patient to do anything, and you do a functional MR and you can see what their resting state MR function looks like and how that's disrupted and so on. I think slowly that will come into clinical practice, but the difficulty is always the time it takes to do a certain exam, but also the analysis. And we often don't do things just because we don't have the capacity to actually sit down and spend whatever amount of time it takes to do an analysis for every patient. But those things should speed up. So maybe things like AI and computation and so on will get so much better that that side speeds up. So if that speeds up to a level where, it spits out an answer at the console, and then it's your job to interpret it, I think that's when it becomes practical for clinical use, widespread clinical use. So, yeah.
Sure, thank you. Just going to go through the chat. I think there's some questions here. So I want to know about, Anam asks, I want to know about online MSK or neuroradiology programs, as we have no access to NHS or UK programs. I think that may be referring to online fellowships, perhaps. That yeah, if you have any input onto those.
So we have had previous fellows who have also done some of the online fellowships for interest, and I think one of them used, I think it was MRI Online, I can't remember, but they did find it useful in that it gave them some sort of structured cases to go through to just hopefully really hammer home certain learning points. But I haven't used anything myself. If you the course that people used to recommend, which I went on when I was a trainee, was the Stoller course, which again was very, very good. But come to the meetings, come to the BSSR, ESSR, or ISS meetings. The refresher courses are fantastic. We're very, very lucky in the UK to have some incredible radiologists in MSK, great educators, and you go to the meetings, you learn a lot, and I think those are good places to, very high value places to go if you want to find out more about radiology, get up to date, or just get a feel for the field. So I think those meetings I would recommend them.
Yeah, I don't know much about online fellowships in neuro either. I mean, I hear about one or two, but I wouldn't be able to vouch for them. Probably the only one that it may be good to look at is a pediatric neuroradiology fellowship that Dr. Kish Mankad, Mankad, in Great Ormond Street has been involved in setting up, I think. But again, I don't know the details of it. I would expect that to be a good level fellowship.
Thank you. I think that we will conclude the meeting for today. I really appreciate both you, Dr. Das and Dr. McKeon, for coming on this platform and giving an inspirational talk to our attendees. I'm sure a lot of them would have found this very useful, especially for career planning purposes, which is essentially the aim of this series. So thank you very much, and thank you for all the attendees who have come and who've made this webinar a bit of a success, and hope to see you all for the next sessions. Thank you to Marcus and the Royal College for everybody's input. I really appreciate it.
Thank you all.
Thanks everyone. Thank you. Thanks, Tilak.
Let's see.
Bye.